My name's Marina. I'm a nurse, to start off, which is good as to why they've asked me to have a chat today. I work over at North Shore Hospital, and for me, I'm very lucky. I only see people that have got primary brain tumours, whereas a lot of other nurses and allied health and support people that I work with do multiple different tumour streams. So to some degree, I think my job's a little bit easier. Just work out. That could be the end of the talk now. But it's not. That's the last slide, and thank you. No. No, I was joking. Liz, that was a joke. So as nurses, we're not just a nurse. We deal with patients with brain tumours, and we know that multidisciplinary approach is vital, which is really what Dawn was saying in OT. You know, when you've got people that have got primary brain tumours, you need to have a multidisciplinary team with OT, social workers, your surgeons, your med-onc, your rad-onc, the whole kit and caboodle, all on the same page, that are all, you know, have you in their best interest. Or is that the right word? And there's big issues for people that have got been newly diagnosed with brain tumours. The diagnosis is out of the blue, it's usually sudden, it's usually pretty quick. The symptoms, you know, people bounce into emergency or have a seizure or have a headache. Things are pretty rapid. The new information is hard to absorb. The language is different, it's new words. I mean, even, you know, I've been nursing for a long time, but the dialogue that we use within brain tumour world is just completely different. And the information's overwhelming. I tend to try and drip feed information because people just don't take it in. They remember small amounts of what you're telling them. And big difficulty navigating the system with multiple teams involved. You know, and years ago people used to work in silos, so you'd have your neurosurgeon, your radiation oncologist, your medical oncologist, everybody working independently, whereas today we're a little bit luckier where people actually work together. But it can sometimes be at multiple different hospitals, and I've had an experience recently with my own family member that's been diagnosed with a cancer, and who felt that they shouldn't tell us because they were trying to protect us. And when she came out of the meeting, she was just literally given all these bits of paper, didn't know where to go to get these appointments made, who to get followed up with. And even for me, I actually, working in the health system, I actually had to ring up a friend and ask what this particular hospital was, because I'd never heard of it. You know, so there was little centres that had popped up. And obviously for this patient group, the issues around no driving, so you're heavily relying on a carer. And for me as a nurse, I heavily rely on the carers. And the no driving issue is a big thing. And I think I actually need to speak to the Cancer Council people, because I didn't know they provided transport, but that would be a massive benefit for patients. So furthermore, there's the loss of income, increased cost of drugs, treatment. We've heard numerous times today about the cost burden and how it's one of the biggest financially, you know, treacherous sort of things. There's great financial stress. Again, the inability to drive and the loss of independence. You have the change in relationships with your partner, the children, especially if the kids are a little bit younger or teenage. I think it just puts massive stress on patients and the whole family as a whole. Can sometimes be personality changes as well. Changes of roles within the family unit and then at work as well, where some people just can't return to work, or if they do return to work, they return to work having to do different duties than what they previously did. So just going back to where the nurse can help you, you know, the complexity of case management for this patient group, or for these patients, is because there's so many different clinicians in allied health and you need all of them. And the thing is that these, I think I've got two slides at the same time anyway, you end up with, you know, going in and out of services multiple times as well. So you might have surgery a couple of times, you go to the radiation oncologist, med-onc come in and out. The OT can be seen at different parts or different times of the, you know, your trajectory. Same with physio, you know, you might need it now, but you need it down the track. So it's about re-referral into things. So from a nursing perspective, and somebody that's tracking you along the way can feed you back in and re-refer you back into these systems. So care coordination or nursing care is essential to communication and coordination of all health professionals, providing a link and support back to the patient and family. Patients often describe the pathway, and when they first get in, they just get really confused about what's going on and who's who in the zoo. And they can describe the process as being a completely bewildering maze, and I completely understand that. Even working within the sector, sometimes you get confused about, you know, which pathway people are going on. So the complexity of cancer diagnosis and treatment in a broad range of settings within settings in each care is delivered means that care can be disjointed. So very disjointed, very confusing, and sometimes patients can miss out on much needed support and become lost in the system. So if you have surgery and you don't get referred on to someone, then what happens to you unless you've got a family member who are jumping up and down a little bit? So nurses can be that patient navigator, the educator, support provider, a point of contact. The biggest thing that I get, because I carry a phone, whether that's good or bad, I don't know, but most information that I get back from people is that they can just talk to somebody. They can get on the phone and have a chat with somebody that they feel is part of their treatment team. And massively to support the carer. I get a lot of, it's about, you know, where carers ring up and they just want to chat about things and chat about what's going on at home, and get support that way. I just want to say that, you know, even though I'm a nurse and I'm really big into care coordination and it's one of my passions, and I primarily deal with people that have got brain tumours, I think that if you've got any kind of support that's going to help you navigate the system, whether it's a social worker, an OT, a physio, whoever it is that's going to actually help you get through and manage different things, is going to be a benefit. I mean, I personally think that nursing, you know, provide extra supports because we're a bit more knowledgeable about medications, bloods, medication, interaction, those sorts of things. But, you know, I'm really big that any kind of support is going to be good support. So having a nurse in your corner, it enables an easy supported pathway of care for patients with improved and timely access to services and health professionals. So people feel linked in with the service and the healthcare providers. Care is delivered in a logical, connected and timely manner so that medical and personal needs of the patient are met. And the biggest issue that I sort of see and the area that needs care and support is really around the carers. We know that people that have been diagnosed with primary brain tumours, that there's a fairly onerous care burden, and the carer's role is a complex role. There's big risk of burnout and depression amongst carers. They often have to reduce their hours at work or give up work, so there's that financial stress there as well. A lot of the time with younger patients, the patient that's been diagnosed with the brain tumour can be the primary income source with a young family. Lots of clinic visits when you've been told you can't drive, so somebody's got to bring you in, and then potentially hiring equipment, the cost of that, home modifications, who you get to do that, and then the financial issues. Again, I think that financial stress is one of the biggest impactors for people as well. So accessing your superannuation, knowing how you go about getting carers allowance, disability support, poor Phil, Yeah, that never happened, did it? No. And you know, linking in with people in places like Centrelink, Cancer Council, you know, to access these services. And insurance reports. I'm sure that lots of the health professionals here, I mean, I live in an area that's probably patients are fairly supported because a lot of them do have income protection. But then for us, it's about filling in the insurance reports to make sure that their income is ongoing. And then, of course, the need to address the psychological and social wellbeing of patients and caregivers. And, you know, the one thing about being a nurse, I think that when you meet that person up front, you stay with them throughout the whole care trajectory. You never sort of really they never leave your pathway, you know, even through to being referred on to palliative care and those end-of-life services if that happens. And for me as a nurse, that's probably the biggest thing I enjoy about my job, is that you're seeing people continuously and you do develop professional relationships with people, you know, and that to me is an important part of what I do. So nursing has an integral role in promoting quality of life. We know that people who are educated, they're informed about, you know, where they're going, what they're doing, and they have a better access into the system, have less stress, you know, whereas those who aren't well educated about the care trajectory and what's happening and medications and what pathway they need to follow are highly stressed, which is, you know, pretty common sense. So nurses can provide clinical care advice. As I said, you know, we see quite a bit of headaches, nausea, vomiting, symptoms of brain swelling, so those sorts of things. Support and counselling of the emotional well-being of patients and their partners. And, you know, I tend to do quite a lot of over-phone chats with carers where they just want somebody to talk to who know their story. And then referring into allied health, social worker, physio, Cancer Council, BTAA, those supports. And as I said, it changes throughout the time. So where you may need it initially, you may not need physio for a while or rehab, and then, you know, something changes and you need re-referral back into there. And also early intervention and access to medical staff. And the one point of contact, people like the fact that they're not having to tell their story over and over again, that you actually know them. And I've had people that, I've been in my role for 8 or 9 years now, and I've had people that have rung, you know, we're part of our service from 8 years ago, and they'll ring up and I still know who they are, you know, and I think that's a nice thing for people to feel. And the big part of it is around the continuity of care. You know, as I said, it's the not having to tell your story again. You know that person, you know, whether they've had clots or seizures or, you know, whatever's been going on within. Whereas I think when you've got people like registrars or residents who are changing throughout the time, you're having to retell your story again. Yeah.